First, find the head of the first metatarsal. It begins to flare at the base where the first cuneiform bone projects. Moving proximately along the medial border, the next large bony prominence is the navicular tubercle. The navicular articulates distally with 3 cuneiforms and laterally with the cuboid bone. Immediately proximal to the navicular, verting the forefoot causes the head of the talus to jut out. If you draw a line between the medial malleolus and the navicular and then bisect the line, you will be over the head of the talus. Move proximally distal to the end of the tibia. Move plantarward about 2 centimeters from the distal end of the medial malleolus, so finger width. It is a small and serves as an attachment of the spring ligament.
The tubercle of the talus is barely palpable, immediately posterior to the distal end of the malleolus. The fifth metatarsal bone, lateral side of the ball of the foot. The head of the fifth is usually the most prominent up here. Styloid process of the fifth metatarsal. After the metatarsal flare, move laterally on the head of the fifth and palpate the protrusion. This is the insertion site of the peroneus brevis. Calcaneus. Move proximally along the foot, lateral border, and the posterior portion is the calcaneus. The peroneal tubercle on the calcaneus distal to the lateral malleolus separates the peroneus brevis and longus tendon. The lateral malleolus is on the distal end of the tibia and on the lateral side.
Stabilize patient's foot by grasping the calcaneus and place thumb of free hand in the depression anterior to the lateral malleolus. It contains the extensor digitorum brevis. Invert and plantar flex the foot. A small portion of the dome becomes palpable, more to palpable on the lateral side. Proximal to the talus, can't palpate the joint itself, but you can palpate a slight depression over it. Bare posterior third of the dome protrudes from behind the ankle joint. If you begin at the malleoli and move plantarward and posteriorly, the protruding bone is the calcaneus. The superior portion of the bone that protrudes is the dome of the calcaneus, marked posteriorly and medially. Lies on the medial plantar surface of the calcaneus, broad and rather large, provides an attachment site for the abductor hallucis. Medially and flexor digitorum brevis and plantar aponeurosis anteriorly. Palpate the longitudinal arch past the base of the first metatarsal bone to the first metatarsophalangeal joint. If you press firmly, you may feel 2 small bones. Place the thumb on the plantar surface and your index finger on the dorsal surface. The metatarsal bones are directly behind the transverse arch of the foot.
The medial collateral ligament of the ankle joint, just inferior to the medial malleolus. It is broad and strong and not easy to palpate. Only the superficial is palpable in a healthy ankle. Grasp the forefoot of the calcaneus with one hand and place finger over the deltoid ligament right underneath the medial malleolus. Evert the foot and press down. You should feel a little springy structure, and this should be the deltoid ligament. From the medial malleolus, palpate the soft tissue depression between its posterior aspect and the Achilles tendon. This structure is the most anterior. You must have the patient invert and plantar flex their foot. Just behind the tibialis posterior tendon and slightly above the malleolus, have patient flex toes while you resist to palpate. However, it is generally found closer to the plantar surface of the foot, notified by the dotted line. cannot be palpated unless symptomatic, runs along the posterior aspect of the tibia and grooves the posterior aspect of the talus. Between the tendons of the flexor digitorum longus and the flexor hallucis longus, foot should be relaxed and non-weight bearing, indicated by yellow line. Posterior and lateral to the posterior tibial artery, difficult to palpate unless symptomatic. Most prominent, most medial of the three tendons, instruct the patient to dorsiflex and invert the foot against resistance. Palpate the distally to its insertion on the medial aspect of the base of the first metatarsal and first cuneiform bones. The mesobelly is on the lateral side of the tibial shaft. Immediately laterally to the tibialis anterior tendon, instruct patient to actively extend the great toe. Palpated along the dorsum of the foot to its insertion into the base of the distal phalanx of the big toe. Lies laterally to the extensor hallucis longus. Palpate it first where it crosses the ankle joint. Have patient extend toes and then palpate the tendon as it splits into four parts to distal phalanx of each of the lesser toes. Lies between the extensor hallucis longus and the dorsum of the foot, absent 12 to 15% of the time. Boom.
Anterior talofibular ligament. Undergoes stress when the ankle is inverted and plantar flexed. Runs from the anterior portion of the lateral malleolus to the lateral aspect of the talar neck. Most easily palpated in the sinus tarsi. Calcaneofibular ligament. Stretches plantward-wise to the lateral wall of the calcaneus. Posterior talofibular ligament. Originates on the posterior edge of the lateral malleolus, the small tubercle on the calcaneus on the posterior aspect of the talus. Prevents slippage of the fibula onto the talus. Peroneus longus and brevis tendons. Pass behind the lateral malleolus as they cross the ankle joint. Have patient actively evert and plantar flex foot. Then continue to palpate the brevis to the peroneal tubercle. The peroneal tendon is marked. Peroneus longus is also there, and the peroneus brevis tendon. Calcaneal bursa lies between the anterior surface of the Achilles tendon and the bare posterior superior angle of the calcaneus. Start at the Achilles tendon, palpate down in, and once you get to the calcaneus, you'll be pinching the retrocalcaneal bursa. Calcaneal bursa. Move finger outwards superficially and is between the Achilles tendon and the overlying skin. Plantar aponeurosis, or the plantar fascia, originates on the medial tuberosity of the calcaneus and splays out to each of the toes. By palpating the plantar aspect of the foot, beginning at the calcaneus tuberosity, you should feel a large, smooth, non-nodular surface. Extension of the toes causes the plantar fascia to be more prominent in the area.